Good evening, everyone. Um, welcome to today's panel discussion from AFPI Karnataka. The topic for today's panel discussion is the key role of family physicians in public health. What are the opportunities and challenges faced by them? So, family physicians play an important role in leadership in public health. This is very obvious over the last 2 to 3 years. So we have eminent speakers in this panel discussion. To moderate the session, we have Dr. Akshay S. Dinesh. Dr. Akshay S. Dinesh needs no introduction for family physicians of Karnataka as well as around India. He is a consultant in primary care, public health, medical law and ethics, and digital health. He works for health equality through bringing an interdisciplinary approach to medicine. Our editor of AFPI Karnataka newsletter. He is also an honorary associate with the Institute of Public Health, Bangalore, under chronic conditions and public policies cluster. And he is a life support trainer in Jeevaraksha initiative by Rajiv Gandhi University of Health Sciences. Over to Dr. Akshay to moderate the session. Welcome, Dr. Akshay.
Thank you, Samya. Thank you for that introduction. Thank you, everyone, for joining. We hope to have a good session. I'll just share my screen to start the.
Meanwhile, few housekeeping announcements. All of us will be muted and questions can be taken at the end of the session. Each session is split into various parts. At the end of every sub-session, 1 or 2 questions can be taken. And if time permits, a couple of more questions can be taken at the end of the final discussion. Over to Dr. Akshay.
Thank you, Dr. Samya. The topic has been shared with everyone, but the question that we should kind of keep in our mind when we are listening to our panelists today is what is the role of family physician in primary care? What is the role of family physician in public health? Are these questions the same, or is there a difference between these two questions? If so, and I would think that we are all accustomed to the answer of the question family medicine and primary care, how are they connected? But then how is family medicine related to public health? And that is the real difference in today's session that we need to bring out. In fact, in a recent editorial in JFMPC, this was discussed at length on why we need to identify public health and primary care as disparate entities and what the roles of family physicians in each are. So in South Africa, it has been studied by one of those others. There are 6 roles as seen by the district administrators as to family physicians that family physicians play in the district health system. And I'm sure our panelists will also cover this, but there is on one side, there is the primary care role, care provider, consultant, capacity builder and trainer. But then it also overlaps with the public health perspective of how does building teams in primary care, how do you advocate for your patients, what kind of policy interventions do you make, what governance interventions are you making? So all of these are also coming up as roles of family physician. And now the question in front of us is, how does this apply to India? What are the key roles of the Indian family physician in our public health system? And let us hear from our panel on what the roles are. So I'll not introduce everyone together because it will be slightly boring. So I'll start with Dr. B.C. Rao, who will now open the panel. But then afterwards, every panelist will get a 15-minute section where they present from their experience, from their work, a bit about what they think about the topic and how they relate with the topic. And in each section, you will be able to ask a couple of questions like so some said. And in the end, we will have some general discussions. So there is a form which we are going to share in the chat, which at the end of the talk or even at the beginning of the panel, if you feel like this is something that interests you, that you need to get active in some of these public health related activities, please fill this form. We'll share this in the chat also. It'll ask for your contact details and what interests are, so that from AFPI Karnataka, whenever there's an activity that connects with public health, we can reach out to you and get you involved. Please don't think that it will be a huge burden or anything like that. There are various forms, and like we will see in the panel today, there are various ways of engagement. There are ways in which a month you can spend an hour maximum and still contribute to public health, and there are ways to involve in much more capacity. So we'll talk about that as well. So I'm just gonna introduce Dr. Rao just for the sake of completeness, although there's no need to introduce Dr. Rao. Dr. Rao is one of the earliest DNBs in family medicine. He's been a teacher and trainer. He's built lots of communities around family medicine. He's built the Family Physician Association. There is a GP club that he runs, which he fondly talks about. Lots of experiences from that. He has been a prolific writer, blogger. He has multiple papers to his credit, and he's been in the domain of family medicine forever. So we'll first hear from him about the topic. Then we'll move to the next panelist. Sir.
Akshay, thank you very much for that rather exaggerated introduction. Now, as you rightly pointed out, the family medicine practitioner and the public health practitioner are actually allies. But to the scope, to enlarge the scope of family medicine practitioner, so that he becomes an effective public health doctor also, there are certain, acts a family medicine doctor must take. Right now, a family medicine practitioner has a set of family units. The numbers may vary depending on the kind of practice one has, but essentially it is a unit-based practice spread over a kind of a geographical area, but it is not a defined geographical area. Now, a family medicine doctor in his practice is already to some extent a public health practitioner also. Supposing he is giving nutrition advice to a diabetic, he's already doing some public health work. Or if he is advising a diabetic as to how to use a glucometer, he is doing already some public health work. But then if you want to really, open up your horizon and look beyond and become a real practitioner as well as a public health worker, you have to do certain things. The most important action is to devote time apart from your day-to-day practice towards public health work. That means going beyond the confines of your four walls of your clinic. Now, many of you are so stuck because of various reasons that you have a set pattern of work which applies to most of family physician doctors. This binds you to a certain schedule which you may find it difficult to get out of. So my first suggestion is you must devote time which is outside your clinic. And then, okay, most of you probably will say, yes, I can find some time. Then what? See, that is where the problem lies. Now, my suggestion is simple, that what I have observed and what I have gone through is that you can always find work if you want to outside your clinic. Whether this is going to be remunerative from the point of view of money, yes and no. But if it is remunerative from the point of satisfaction and pleasure, certainly yes. Now, I'll give you certain examples. See, in your area per practice, there are schools, there are colleges, there are apartment blocks, there are resident welfare associations, and there are women's clubs. This is spread across both in urban as well as in rural and semi-rural areas. Now, these associations and bodies always in need of a doctor for promoting and preventing health illnesses. And then if you volunteer yourself certain time of the week or a day, you're always welcome. So that is a start for you. And over years of doing this work, you will develop a huge network of like-minded people, both in the profession as well as outside the profession, which has been the experience of some of us. And your life becomes so much richer and better if you indulge these things apart from working from your clinic. I'm not saying that you should give up your fundamental practice methods, but this will add to the quality of life which you will lead. Now there is electronic media, the social the media, and then you can make use of these. You can start a kind of a newsletter amongst your own patients and their friends by collecting number of their IDs, email IDs, and start a electronic journal or a newsletter. That itself is public health work. You can what's happening in the field of health, you can update them. So opportunities are plenty, but it means a certain amount of devoting time. And I say with confidence that there is no risk involved. About earning a few extra pennies, that most of you doctors in private medical practice will not starve. I guarantee you. But then over the years, it might even add to your income. Doctors are always, they're already having a built-in schedule of health. My recommendation is please enlarge your horizon there also. So you are supposed to visit sub-health center on a given day. You're supposed to go to the Anganwadi and meet up with those. Find out their problems, train them, become a trainer, and then go to the panchayat offices and find out how those villagers are, what are their problems. So become proactive. It adds a lot of meaning to your life. And I suppose this is what it is. Ultimately, you have to find your own way of doing things, but there are plenty of opportunities, and public health, as you know, is the most important field of medicine, especially for developing countries like ours. It's no gainsaying that I would say there's a pillar of health, and general practitioners and family medicine that guys are best suited to fill this role and then deliver quality healthcare, both promotive and preventive aspects. Curative aspects you're already doing, as this epidemic has demonstrated. But for you all, we would have had a calamitous situation in this country. It may not have been recognized by the authorities. They're looking at hospital-based cure. But I tell you, what you have done in this during these 3 waves is phenomenal. And that is where the example of public health really is. You did this not necessarily sitting in the clinic, but I have known some of you have handled thousands of cases in telemedicine. So that becomes a habit. This can be applied to all kinds of non-communicable diseases. So that's it. Akshay, you have any queries to you? I can answer them. But this is what I wanted to say. The opportunities are plenty. Challenges are not really that great when once you get out of your clinic and start.
Thank you, sir. The audience, please feel free to type in any question that you have at any moment. If we have time, we'll take it at right away, or otherwise we'll have the questions read out at the end, and the panelists will be answering. Sir, I will now move to Dr. Duju's section, and then we will come back to you, sir, at the end. So just to introduce Dr. Dwiju, Dr. Dwijavanthi Kumar. She is an attending family medicine physician at One Community Health and OB physician lead UC Davis volunteer clinical faculty, and also the program director of the AFPI, Karnataka AFPI Primary Care Leadership Fellowship, which is what she will talk about today. She has an MD and an MPH from the University of Iowa. She's born in Bangalore and immigrated to US at the age of 7, but she has worked with various organizations and believes in high quality healthcare as a human right. Her interests are women's health, prenatal care, outpatient procedures, public health, and working towards health equity. I will request Dwiju to present these slides, and then once Dr. Dwiju, are you here?
Hi, everyone. Thank you for having us. And thank you, Akshay, for organizing this wonderful panel presentation. We are honored to be part of it. And we are grateful to be able to share the work that we have been doing over the past few years. So let me share my slides. 1 second. And then let me know if you are able to see the screen.
Yes.
Okay, great. So, I think we are, like I said, I'm very happy and honored to be part of such a wonderful group of physicians. And I know everyone is interested in moving forward the concept and the movement of primary care, and especially family medicine. And so me and my husband, Eric Wilson, both are family medicine doctors in the US, and both have a keen interest in global health and, achieving health equity, or at least eliminating some health disparities that we have witnessed and know to exist in India. And so we wanted to continue contributing in some way, and found a sustainable and wonderful way through this fellowship program, which we were very lucky to start and initiate with Dr. Rao, Dr. RK, Dr. Akshay, and Dr. Swati, who all share the same vision that we have in improving primary care in India, improving family medicine in India, and especially focusing on the leadership skills of doctors, especially medical officers. So what we identified was a need in medical officers who work in primary health centers, in that they didn't feel like they had all the skills that they needed to provide high quality, comprehensive primary health care to their underserved and marginalized communities. And so they were interested in more training to kind of improve their skills. And so we started this fellowship program for that reason, with the partnership of Karuna Trust, which runs some of the really great primary health centers in the urban and rural areas, and of course with the support of AFPI as well. So this is our program vision, is to improve the training of the next generation of leaders in primary care in India, and to inspire those physicians to develop practices that address all aspects of comprehensive primary care, including promotive, preventive, curative, and rehabilitative. And we know that family medicine is a specialty that requires extra training and extra skills and tools. And so the newly graduated MBBS doctors, felt like they didn't have all the tools to provide this comprehensive primary care. And so we wanted to provide some of that training, and especially do it via a remote learning platform, so that we can eliminate the need for travel and try to accommodate as many medical officers as possible from different health centers. So this is our fellowship team, core fellowship team. It's growing now, but our senior advisors, we are very grateful to have Dr. Sudarshan and Dr. Rao as our senior advisors. And Dr. Rao also participates quite willingly and enthusiastically in many of the sessions. And we are very grateful for his expertise and experience in leadership and family medicine. We also have a program advisor, Dr. Shailendra Prasad from the University of Minnesota, who advises us on building the curriculum and evaluation and in family medicine education. He is he's a faculty at the University of Minnesota College of Medicine and runs a global health center there. And our core faculty, mentoring faculty are, of course, Dr. R.K. Prasad, who has been instrumental in navigational leadership of this fellowship, as well as the day-to-day proceedings. Myself, my husband, Dr. Eric Wilson, Swati, who has been just unbelievably wonderful and really instrumental as well in this fellowship, and of course Akshay, who's also been instrumental and helpful in so many ways. And we have newly hired a program coordinator to help us, Samarth, who has also joined our team, and looking forward to working with him more. And we have a few more people who have recently joined, so we're thankful for them as well. So this is the primary care certificate program, and I'll have Eric go over that if he's able to do that now.
Yeah, thank you, Dwijo. So this is a kind of a concept map of our program, and I think it covers all of those areas that Dwijo had mentioned in our program vision, as far as how do we see family doctors working in many different areas. And we'd be happy to share this with the larger group as well, if there's any interest in the different areas. But these are all the topic areas we are trying to touch on in our fellowship. And of course, we have a very large focus on leadership as well. But I think in referencing the topic for today's panel discussion as well, we recognize that primary care really is public health, and so we work with our fellows on how can we influence health policy, how can we view the work that we do in a public health lens, because certainly the medical officers in the primary health centers are part of that base of primary care that's serving the Indian population. So, Dwijo, I think it's fine to move on from here. And we're approaching our fellows and their learning needs and trying to help them with their lifelong learning cycle. And so this is where we find ourselves playing a role with them, is that we're trying to help them understand that family medicine and working in family medicine is really lifelong learning. And so we are not there to provide the specific information that they need to treat their patients, because every public health center is a little unique in terms of its resources or in terms of its patient population. But we are there to try to help them have the resources they need, use those resources effectively, update their knowledge, and then use that updated knowledge in their setting to better improve the care and health of their community. I think you can go to the next slide, Dwijo. And that also references how we're going to be evaluating our fellows, and how do we evaluate whether or not our program is effective in achieving its goal of improving the leadership of our fellows and also improving the health outcomes of the communities in which they work. And this is a framework for how we are evaluating them, where we are trying to understand through immediate session feedback whether or not that session was helpful in improving their understanding and their knowledge of the learning objective. And then in the future, in quarterly evaluations and biannual evaluations, we'll be checking with supervisors, with staff in their health centers, and working on some other measurement metrics to understand if their behaviors are actually changing. Meaning, are they implementing these leadership skills? Are they implementing the knowledge that we are helping them to improve? Are they helping to change the attitudes or procedures in the clinic to better serve their communities? And so we are trying to help them move up this pyramid in whatever ways they need. You can go ahead, Jojo.
Okay, and I just want to go back to the certificate map just 1 second. And I wanted to just emphasize that our fellowship is different, than the traditional kind of MBBS or any sort of didactic learning program, where we are not there to just lecture the fellows, and we're not there to just teach the topics. We're there to facilitate learning, and that we're all adult learners, practicing physicians and adult learners. And so we try to approach it in that way, in a case-based discussion format. And so we encourage participation and discussion and things like that every session. And we also, as we had mentioned before, really emphasize the leadership portion of the fellowship, because we think that is so important. We want to inspire the fellows, the medical officers, to realize their full potential as leaders in the medical, in the primary health center, and also as leaders in the community. And so we want to facilitate learning and inspire them to understand how they can use their skills and their power as physicians and leaders in their community to advocate for themselves, for their patients, and their communities in different ways. And so one of the big projects of our fellowship is a quality improvement project that all of our fellows must participate in. And it can be something small, and it can be, something big also, but anything in their clinic that they want to improve, we help them and teach them the skills of quality improvement so that they can understand how to do that in a systematic way, and so that they can continue to do that beyond our fellowship as well. And we also talk about advocacy in different ways, in writing, in engaging with the government, local government, and advocating for policies, and in different ways of using that leadership role, and team-based care and communication and working with the team in the primary health center as well. So as you can see, we cover a lot of topics that are not just curative care that we may think of, but also, like the focus of this panel session is that as it was mentioned before, family medicine doctors are perfectly suited to participate in the interface of primary healthcare and public health, and many of these things are trying to facilitate that. So community engagement, as well as shared decision making, quality improvement, evidence-based medicine, community leadership, and things like that. So we had some quotes from some of the evaluations that I wanted to go over. One of the fellows said, there are many courses which teach clinical knowledge, but here leadership is an important part of the curriculum, which makes it more valuable than other fellowship and courses. Someone else said they implemented the PDSA cycle or model for all of the new projects and surveys involving pulse polio, COVID care, and other such assignments. This has helped to solve the problems in all our new projects and programs. Someone else said, this fellowship has helped me a lot in developing my clinical knowledge, gave platform for enhancing my knowledge, provided platform for sharing my experiences and sharing stories in my practice, and taught me about the importance of counseling the patients, where to look for the resources and to teach the public about social determinants of health that influence people. And it taught me about leadership qualities that are needed to lead my team. So we are hopeful that our fellowship is meeting a need, and that it is improving in itself year by year. We are in our third year, and we want to keep improving, and so we're trying to do that. And we're learning a lot from our team. We're building a team of excellent people with diverse backgrounds and knowledge. So we are excited about that. And we are also looking forward to your questions and thoughts and feedback. And thank you for having us here. There's some pictures, I think, of the graduation ceremony last time. I think that's the last slide. So we have all of our core faculty here. So if they want to add anything, please go ahead.
I think, like Rao was saying, this is an excellent example of how just by looking out of the confines of a clinic, even though Dr. Dwiju, Dr. Rek are in the US, there's a time zone difference and all of that, because the technology today allows us to engage with public health in various ways that are not really restricted to, be physically being there. So just by thinking outside the confines of our four walls of the clinic, like Dr. Ravasa was saying, we will be able to do a lot. Any questions to Dr. Eric or Dwiju, please feel free to put in the chat. Dr. Dwiju, there's a question from Tanya. Much expected from the program could be overwhelming for a primary care physician. Could we consider a framework that reflects the path of growth as well across these components? Some of these concepts appear basic, whereas some complex and may or raise awareness. Perhaps more of a comment.
Thank you, Dr. Tanya, for that. Yes, we agree. I think it does seem the map, especially, there's a lot of topics, and we certainly don't cover all of them, in great depth or detail. But I think it's important for family medicine physicians to know about these concepts, and that's our role. We are not there, and we emphasize that we're not there to teach them everything about all of these things, but to raise awareness and to facilitate and to let them know about the resources so that they can be inspired themselves to learn more about these things, and especially to continue learning after this fellowship is over. So that's our goal, and I agree that it is complex, and it's just the nature of nature of providing high quality comprehensive primary care, I think.
There's a comment from Dr. Swapna. Nice to see the diversity and depth of topics that has been included. True to the principles of family medicine, we should look towards engaging with more primary healthcare providers. There's also a couple of questions which I'm going to club together, and I'm just going to ask you now, although we have to wrap up after this question. What's the course fee, and can people join this course? What is it like? Should someone who has already done family medicine should think of joining this course as a candidate? Can they join as a faculty?
Absolutely. I think, the course fee actually, there's an incentive through the Karuna Trust program for medical officers to have an increase in salary after they graduate the fellowship. So that's an incentive for them to participate and join the program. I don't believe that we're charging a course fee at this point, but I think, we are trying to get other sources of funding to help us, with the sustainability of this program, because there is a lot of need for funding. And anyone can definitely join. We are open to observers to any of the sessions, and we're definitely actually looking for guest faculty, because I know, especially in AFPI, there are many experts in family medicine, and many of these experts have niche knowledges and specialty skills, specifically, or special interest in specific topics. So if any of you are interested in being guest faculty, we would be very honored to have you as a guest faculty in our fellowship session.
Thank you, Dwiju, and Eric also. I'll actually move on right now. There are a couple of questions in the chat which are very interesting, but which I think the later panelists will also cover. So I will introduce, there's a small change in the schedule, so I'll introduce Mr. Pawan Kaipa now. He's an engineer and cost accountant by education, but he's worked in diverse sectors: healthcare, education, rural development, politics. So you name it, he has done it. He has worked with Narendra Modi campaign management team. He has worked with MPs. In healthcare, he has worked in a tribal area of Narmada district in Gujarat. He's also run multi-specialty hospitals in Gujarat, in Muscat. He's also run a number of PHCs through health tech startup known as Grameen Healthcare. Presently, he's a public health consultant working closely with GCMS, Restore Health and associate projects. So I invite Pawan to talk about topic.
Thanks, Akshay. Thanks to AFPI, its various channels, and the entire team for the opportunity to be here. So I'll just discuss, just touch upon a few points from my decade-long experience, and we'll touch upon certain points from the project Arogya Arali, which we are expected to start in the Chamarajanagar district soon. So some of these points are, are pretty much well known to all of you being practitioners yourselves. But sometimes it's just a gentle reminder for us to just, take a step back and look at the bigger picture. Akshay, if you could move to the next slide. So my work majorly in healthcare has been in rural Gujarat for a while, rural Uttar Pradesh for a while, and a little bit in Karnataka, and I hope to continue a lot more here in Karnataka. So what have I learned? What have I experienced? More emphasis is obviously required on primary healthcare, especially if we are to cover the last mile, as it is known. There is quite a discussion on what is the last mile, and should the last mile be viewed as the first mile. That's probably a topic that we can cover some other day. But obviously, as we all know, a lot of more emphasis is required on primary healthcare to ensure that the undeserved or the unreachable population are served in a better manner. Family physicians may be highly underrated, but are very crucial to the ecosystem. Sometimes at times with the present healthcare systems that that operate more in a corporatized manner, at times we probably undervalue our value or importance to the ecosystem. But having seen this from operational or project point of view, I can definitely say that family physicians are extremely crucial to the whole ecosystem. Our ecosystem, the general health ecosystem, is largely fragmented. We have a lot of players, a lot of partners who are doing really good work. But unless there's a lot more collaboration, unless a lot more partnerships evolve out of the different players in the ecosystem, probably we won't be achieving genuine outcomes. There are corporate players, there are a number of NGOs, there are a number of startups, there are a number of different types of players who are doing their own bit. But if we are to achieve a larger goal in public health and general healthcare outcomes, a lot more collaboration is required between different partners. So Narmada district of Gujarat, the Bagpat district of Uttar Pradesh, Chamarajanagar district of Karnataka are largely rural and tribal districts, often lacking affordable and quality healthcare. So having seen a little bit of each of these districts, these are some of my learnings from the ground as such. Now, in terms of Chamarajanagar and what we are trying to do there, there is a project known as Arogya Arali, which we have been talking to the state government over the past few months. And we have paid a few visits to the Chamarajanagar PHCs, the government PHCs, and certain understanding has developed in terms of how we could help the PHCs work better, collaborate better, and strive for better health outcomes. So this is expected to launch over the next few months, and it is something which we'll be working with the Department of Panchayati Raj and Rural Development to ensure that PHCs don't function just as primary healthcare centers, but work along with your Gram Panchayats to ensure that a decentralized mode of healthcare is established, such that communities themselves are able to take ownership of their respective health outcomes. It is not just dependent on one or few people within a primary healthcare center. So, based on our studies and based on the visits that we pay to different health centers, different PHCs, government PHCs, certain initiatives or certain steps have been identified to ensure that we are able to achieve our objectives. How can we ensure emergency preparedness for the PHCs? By creation of SOPs, support for emergency health situations like the Omicron wave. Ensure patients are systematically linked to PHCs. Now, this is a problem not just with the government primary healthcare centers, but a lot with the private centers also. How do we ensure that registration, enrollment systems, to ensure that a long-term community objectives are met, is done in a proper manner, if possible, electronically? Support accreditation. AFPI has an accreditation program which would accredit not just PHCs, but in the long run, we could look to start certification programs for ASHAs and different frontline workers such that they are also recognized and they are able to rise up through such certification also. How do we increase the breadth as well as the depth of care? Breadth of care by initiating different programs such as palliative care. Now, home-based treatment is something which is more of a private concept. A lot of it has been taken up by certain sections of the government, but not completely. So how can this be done at the rural level in a more structured manner is something that we are also trying to work on. Operationalize mobile clinics. Mobile clinics have also started to a large extent, but a lot has to be streamlined, a lot more efficiency has to be brought into the system. How do we organize specialist camps that such that people in far-flung areas, if they are not able to visit specialist doctors in cities or generally in Taiwan, Tier 2 places, how can such specialist doctors be also brought to the last mile? And how can telecare systems be augmented better? How can it be? How can it actually look to better the healthcare systems present? With regard to depth of care, creating optimized referral pathways. As we know that the referral systems generally exist on a very informal basis. There is no structured mechanism to ensure that a patient who is sent from a sub-center or a PHC actually reaches the taluk hospital or the district hospital and ensures that the care continuum is ensured. So that is something that is also going to be worked on. And capacity building of PHC staff to ensure that team dynamics, culture, cross-learning, and opportunity for mentorship and support through programs like the Primary Healthcare Leadership Fellowship are also being planned. So these are some of the steps or some of the thought process that we have gone through over the past few months to ensure that we are able to try to make a difference. And this is something which, as you all can see, is not restricted to government PHCs. These are steps which can be undertaken in any setting, be it an NGO setting, a private setting, or a government setting also. So yeah, this is pretty much it. Thank you very much for the opportunity. Any questions or suggestions, please feel free.
Pawan, while the questions are coming in, I actually think one of the questions I regularly face when presented with big projects like this is how does a family physician who probably has a clinic or a hospital kind of setting that they are working in, how do they engage with government? Or, the words itself sound like they're very far away from us. So how do you, and you work very closely with various political and governmental organizations. How do we build that connection?
Hello.
Yes, Akshay. So I believe that as individual practitioners, not just as individual practitioners, as anyone, government definitely working with the government is something which is considered very tough, and it's something which it's a distant objective for a lot of people. But being an individual and trying to aspire for that may not work as well as being in a group, as a body like AFPI. Now, if AFPI has a group of right-minded doctors or practitioners who want to come together to try to either influence policy, influence implementation, or work on different aspects of public health, I think as a group, it would be much easier to approach different people in the government and try to take this forward rather than trying to do something as an individual basis.
Okay, thank you for that answer. Um, Looking to see if there are any other questions in the chat.
Can I? Hello.
Oh, please, yes.
I am Dr. Rajana, former professor and head of the Department of Community Medicine. I worked at BMC, then KIMS, and then Siddhartha Medical College, Tumkur. And the thing is, see, the community medicine department should be utilized by the primary health center, where 3 primary health centers are attached to community medicine department. So in those 3 primary health center, especially 1 primary health center, they can concentrate. See, they need not concentrate on curative medicine, preventive, promotive, and curative. The first is the preventive, and then promotive, and then curative. And some of the professors are extremely good in communication. So they can conduct. I have conducted plenty of health education program just under the banyan tree. More than 500 villages were there, and I discussed the mode of transmission of different communicable diseases. And the topic should be need based. I underline need based program. For example, I am interested in talking to the people about the diabetes, but they are not interested in diabetes. They are interested in the basics of basic health problems in the rural area. So we have to collect the basic information with the help of the medical students, and then based on the findings of the observations, findings of the study, what are their health needs, uh, basic needs, and then we have to stress on that. And wonderful opportunity, we can request the Anganwadi worker to arrange the program, health education program among the rural women folk, and we can talk to them. I have conducted plenty of programs utilizing the Anganwadi workers and the group of Anganwadi workers. And more than that, see, every time, every day, community medicine professor will not be, and no time for him also, because he will be teaching in the medical college. The best person in the primary health center is the BHE, block level extension educator, or block level extension educator, or block health educator. He is exclusively for health education. But unfortunately, he will be utilized for other purposes. Just like any other health supervisor, he will be utilized. That should not be. So the BHE should be exclusively utilized.
Thank you, Dr. Rajan. I'll have to stop you there because we do not have time.
Sorry, just I wanted to mention the important point.
Thanks
Akshay,
for the
Akshay,
comment.
if you can just give me a minute, sorry.
Yeah.
Thank you, Dr. Rajana. Thank you very much for your comment, especially on the point of need-based assessment and programs. I think a lot of our steps and thought process is very textbook, but obviously everything has to be modified, has to be fine-tuned according to the respective needs of different places, which will vary from taluka to taluka and village to village also. So thank you, sir. Thank you very much.
Also, thank you, Pawan. Thank you, Pawan, for making it very clear how people can engage. We will come back to you if there are more questions. Now we'll move to Dr. Tanya Seshadri, who incidentally has MD in community medicine, and some of the discussions in the chat is around the difference between community medicine and family medicine and things like that. So Tanya is a medical doctor and community health practitioner at Vivekananda Girijana Kalyana Kendra in Bihar Hills. She has worked with NGOs and community health centers in southern and northeast India, helping in setting up managing community health programs. She teaches within community health and public health courses at various universities and facilitates field-based immersions in public health for researchers and students at that field session Bihar Hills. She is now a faculty at Institute of Public Health, Bangalore, and co-leading a grant to establish the Center for Training and Research and Innovation in Tribal Health in Southern Karnataka. So, Tanya, please.
Thank you so much, Akshay, for the introduction. And what an honor to come just after Dr. Rajana has mentioned. He was my professor at KIMS, and as he was talking, so many of my classes was just coming back to me. So yes, my journey started with community medicine as well. I started and I saw myself, I would say, as a community health practitioner. But very quickly I moved with my focus going more towards research, and the exposure I got working at the Institute of Public Health was also one of health systems researcher. So I sort of see myself much more as a public health researcher than a clinician or a community health practitioner as well. But for the last decade, I have been living and working in BR Hills. This is a hill range in South Karnataka, and I've been working with the Soliga people for the last 10 years. So I've sort of shifted back a bit and become a community health practitioner and researcher here. Now, someone was saying, what's the difference between community health, family medicine, etc. Well, the exposure is the kind of work I do is very similar to that of a primary healthcare practitioner. Clinical problems are not really confined to any one domain, and these are more commonly encountered illnesses that I see at various and often they're undifferentiated chronic diseases, emotional problems, minor illnesses, etc. And the way I work also is I work at an NGO, but we work very closely with the government health systems. I work with the sub-center, Tribal Health and Wellness Center, and many of the cases we refer them through the government health systems, as many PHC medical officers do. Some places where I think it departs is the fact that the population that I care for, that is determined by the community, not necessarily by individuals or a village, but by a geography or identity in this case. And my relationship is more towards my relationship with the community, so the leaders, the various community collectives, etc. And again, it's not really patient, physician, or individual, or even hamlet, a particular geography focused. And again, for me, earlier, pre-COVID, actually, patients, outbreaks, even the different kind of conditions for me were not really the center of what I used to work on. These were more how I would see it as symptoms of larger issues in the community. So if and so my focus was not so much on that, but that was the path. That was the path through which I would conduct research, especially on maternal and child health. Now, during the COVID second wave, COVID first wave didn't really touch Chamarajanagar district, but during the COVID second wave, there was this one story that I came across, one of many stories, and I thought I'd sort of share that with you, was a story of a 29-year-old Soliga Anganwadi teacher. Soliga is one of the indigenous communities in this region, and she was a mother of 3 and she was pregnant again and was undergoing her antenatal visits regularly with the nearby primary health center. And for me, so she was part of the system, and the system has a very clear maternal program. So everything was taken care of. There was nothing extra additional that I was looking at. For me, she was a typical antenatal patient. But then she started having cough for about a week. And this was just before this was just when this COVID second wave was starting. So of course, someone mentioned COVID, and then she completely stopped engaging with any health worker. The minute someone from the hospital or anyone came, they would shut their doors, not talk to us because of the fear of COVID. But unfortunately, she had a preterm stillbirth at 24 weeks. And even then, she refused admission, refused to come to the hospital, refused anyone to come near her. Clinically, she had moderate to severe anemia, and we were every day at the doorstep trying to talk to her, talk to the family. Her nutrition was very bad. She was starting to develop cardiac failure, and her cough was worsening. So, but our minds, the minds of everyone in the health, in the government health system at that point was also very focused on COVID. Of course, there was the severe anemia and failure there. So every day we were doing this, every day we were talking, we were bringing in leaders, trying to have multiple conversations. And eventually 5 weeks after, when she was completely bedridden, hardly able to move, they finally agreed. And through essentially the personal relationship that had developed between us, that we finally took her to the district hospital. Even though she was COVID negative, they said this is definitely COVID-like syndrome. That is what everyone had in their minds as well. She was admitted in the COVID hospital, the district dedicated COVID hospital, and she was in the COVID-like syndrome ICU for 10 days. Multiple tests were being done. Everything was being checked, but she wasn't improving. They tried CT lung, they did ultrasound, but something was just not improving in her. And eventually on, I think the 13th day, one of the physicians decided that, let's do an echo just to see what's happening. And it turned out she was actually a case of RHD with severe MS, and she had a massive clot sitting in her left ventricle. And the next step was she was referred to Jayadeva Heart Hospital, Cardiac Hospital in Mysore. But again, she was finally declared non-COVID. And there she was admitted for a week. They said, there's nothing we can do as long as there's a clot, started her on blood thinners, sent her home. And no one really followed up because she came from Jayadeva. So no one even knew she had come back home. Everyone was on COVID duty. Everyone was distracted. They had started her on blood thinners, but they hadn't given her any proton pump inhibitor, no H2 blockers, nothing. She was on very strong antibiotics as well. And she developed severe gastritis, refused to eat. We did not know. I was doing COVID duty at the district hospital at that point of time, but she developed, bouts of hematemesis, melena, and she died 3 days later. So from delivery to death, it was almost 3 months. And the system didn't see her as a mother anymore. For the system, she was not a maternal death. This was not something that anyone had to learn from. All the issues that happened with her were blamed towards superstition, refusing to work with health services, ignorance, illiteracy, etc., etc. And she was eventually forgotten. So this case, when I came back from COVID duty and I found out about this, one of the things we did was everyone just sat together, community leaders, the teams that I work with, and we were talking about what happened, how did this happen, how did we miss a case of RHD, what were the did anyone even do a cardiac checkup? And that's when, through the government health system, even with the PhD medical officer, who incidentally was part of the AFPI fellowship as well, since it was just routine antenatal checkups, no one was bothering so much about cardiac, except for in the first visit, which would have been like early on in the first 2 or 3 months. The other thing was, because she coughed and COVID was what everyone was talking about, no one could think beyond COVID in the government health system, at least. So everything that she was going through was always trying to be rationalized into something COVID, etc. And even when she was started on treatment from Jayadeva, because everyone assumed that this is the super specialist government center where cardiac excellent care is going to be provided, no one really thought to look at what has Jayadeva given, what have they advised, what have they planned. Is she comfortable with it? Is she getting it? Who's going to follow up? So because Jayadeva is a hospital that's not, again, part of the government hospital at the district, government system, there really isn't any follow-up or anyone looking at how she was doing. So this was one of many cases that happened. We had a 9-year-old with type 1 diabetes who developed ketoacidosis 3 times during the COVID pandemic, and we had one case of a 14-year-old who just had fever for a very long time. Everyone said TB, evaluated multiple times, and again she was declared COVID-like syndrome, admitted, then again discharged, and eventually she turned out to be evolving SLE. But it took us almost 9 months before someone started asking questions on what really are her symptoms and what really is, has anyone even examined her? And so for me, in this conversation, I actually, like I said, I started from community medicine, but I eventually moved towards more public health research. But with the working with the community, I came back to being, a mix of community health practitioner, but still focus being on research. But this, especially working through this pandemic, cases like these taught me that there were many very important principles that family medicine brought, that brings to you, that we don't really value enough. For instance, clinical skills, just the value and importance of clinical skills, clinical examination, history taking, evaluation. These are things that are often undervalued, underestimated. They get clubbed under curative, which is considered as the least important at a community, in a community practice. Even at the PHC, it's more about protocols and programs and preventive, promotive. Not in terms of the way, not in terms of the levels of prevention, but what I'm trying to say is that it's often curative or clinical skills are often undervalued. The second aspect that I recognized was that the physician-patient relationship, which is so important and is so different from a community health practitioner relationship, is also very much undervalued and underestimated. The follow-up, the continuity of care, someone keeping track, someone going through the details. Whereas today, patients are often just sent from step to step. Pawan also mentioned about the referrals from, we're talking from the frontline health workers to the PHCs, to then the different tiers, and sometimes they also go to super specialist hospitals. But there is no one really keeping track. There's no one really following up, and there's no one looking at what does all this mean for this particular patient, for this particular context. For instance, in the case that I was mentioning, there was just no way. She lived in one of the interior forest settlements. There was no way to monitor her bleeding tendencies, clotting tendencies. But for the kind of medicines that she was started on, but the cardiologist who did start her on those medications had told her very clearly that every 3 days you need to get these tests done, and had just sent her away. So there was not so much thinking about also, would she be able to do this? Should we keep her longer? She's been through a very long journey. But where I see opportunities for, and actually that's when I enrolled into the PG diploma for family medicine. So that's where now I'm hoping also to, I'm learning and entering this world of family practice that many of you are in. But some of the points where I'm able to see, very important values for family practice in the system from within it is, one is, like I said, this patient follow-up and tracking, which is completely missing, even in the primary healthcare system, because of absence of medical records, absence of even a clear tracking system. Second is culturally and, customized, safe treatment for people, looking at the context. That approach is there at the public health program planning, but it's not so much actually practiced at the level of the physician, even at the primary health center. And of course, like the kind of cases I've been seeing through COVID, I recognize that a family practice clinic is also a very important point for monitoring and watching what are the different conditions that are emerging in the community. We have now seen something like 3 lean diabetes cases, and lean diabetes is one of those conversations happening within different tribal health practitioners in India, where we see very young people developing a type 2 diabetes, but which is insulin dependent. And so there are a lot of cases that we have been sharing and we have been discussing. So these family practice clinics are often also these sentinel points for servants. But of course, where my community health comes in very importantly is the relationship with the community and the understanding of the context. Because that I find often that my colleagues who are family practitioners also, that sometimes while they have this relationship with the individuals, that often they aren't investing enough at the community level. Now in rural areas, it sometimes does happen because you're living in the community, often, not necessarily always, but if you're living in a hobly or a village level, then your understanding of the community, relationship with the community, very important. But then that sometimes gets lost as you move towards towns and larger cities. And also some of the values of public health, I think in the kind of conversations that happen, I heard in the family primary care leadership program, the concepts of equity being spoken about, so, but also concepts of social justice, solidarity, principles that guide a lot of population health, community health work, and public health policies as well. I think trying to look at how do those translate into my practice, and how does that translate also into the way I engage with the system. Not necessarily always, Akshay, I heard your question, not necessarily always as how can I work with the government, but I am a citizen and I am a health practitioner. So there is a role, there is an importance. I engage with the government as an NGO, but also as thanks to COVID, there have also been a lot of opportunities where there have been task forces, committees, collaborations that have been called for. So I've been participating in many of these coalitions. So I think the collective, that is where also one of those strengths come. Today where I am is I think I've stopped labeling myself as public health or community health. I think whichever group comes and talks to me, I am that. And that's the only way that I think in my mind and in my work, I'm able to take the best out of the three, but also understand the limitations of each. So today my focus is just as much on clinical guidelines, but I also recognize that clinical guidelines are very different sometimes from the public health system guidelines. And so there's a lot of negotiation. So that's the conversation in which I seek inputs from various mentors, like from AFPI as well. The last thing I just want to say is so we've recently had internship postings that have happened. And what I found very useful is when people come now, the conversation where I can bring public health to a medical student is by starting to talk from a family practice approach, because that is something a student is easily able to understand and gauge. Whereas if I start talking community health in terms of epidemiologies and population health, I know I've already lost the conversation. I know they're already asleep mentally, even if their eyes are open. So family practice. So I feel that even in medical education, it's really a great opportunity to bring that exposure for interns, during their, for instance, their community medicine posting could be one start. Dr. Rajana was talking about the PHC postings that they have. Like I said, an engagement with the government for the various family practitioners. It does seem a little artificial, even for community medicine practitioners, it's the same struggle. And I saw the editorial recently also about community medicine and its relevance in the current health system. So yeah, we're all in the same, what do you call it, bisi bade baat of conversations on who is important or where. But yeah, I think with that, I'll end that there. And I'm happy to take comments, conversations, and maybe you can explain it to me as well, what community medicine is. Thank you.
Thank you so much, Tanya. You always bring the middle ground into the conversation. I've appreciated that in many of the conversations. And thank you also for preemptively answering many of the questions I had listed in my mind. There doesn't seem to be any question in the chat either. So I'll just move to the Dr. Ashoojit and Prathamesh for now. There's a comment by Colonel Mohan Kubendra on family medicine specialists in CHCs. I hope you can read that. Let me introduce, meanwhile, Dr. Ashoojit and Dr. Prathamesh. So Ashoojit is the clinical director at PCMH Restore Health, and also the founder and chief mentor at Aveksha Home-Based Primary Care Program, which has a mission to deliver world-class, compassionate, and comprehensive healthcare services to people and improve their quality of life by adding life to years and not merely years to life. I think this is also something that resonates deeply with Ashoojit's own personal mission. She has more than 2 decades of experience working as family physician, as consultant in geriatrics, palliative care, HIV/AIDS. I mean, she has trained a lot of people, a lot of healthcare workers. She has worked in in institutions such as Baptist Hospital, Ambedkar, Accept Society, People Tree Hospital, lots of publications. Ashoojit is also going to talk with Dr. Prathamesh, who is the co-founder and executive director of Aveksha. He's also the lead clinical pharmacist practitioner at PCMS Restore Health. So he works to understand and enhance drug-body compatibility in shared decisions with an interdisciplinary clinical team. So basically, the team the team that Aveksha is building is built by Dr. Prathamesh and Dr. Ashoojit. So I am excited to hear from them about their experience in. Shall I share the presentation as well? Let's see. You can start talking now.
Sure. Thank you, Akshay. That was quite an introduction. Okay. So I think many on this platform already are aware of our work at PCMH Restore Health and Aveksha, which is the home-based primary care. And it's my pleasure to be here. And thank you so much for having us here. With me is Dr. Prathamesh as well. And he, like he said, he's a co-lead on this Aveksha program. And he's a clinical pharmacist. So our main thing is what we are going to, Akshay, can we move to the next slide? So today's objective of this session is that we will just demonstrate one case scenario we present, which will exactly tell us how how we can bridge between primary care and public health. And we also would like to demonstrate a team-based approach, which we always have at PCMH Restore Health. So it's not just the physician or the doctor who provides the care, but an entire team, which has the clinical pharmacist, we have a psychologist and a physiotherapist, and many other MPH students, interns. In our ecosystem, we have the molecular lab as well. So all that, how we work as a team and how it delivered to a patient and the family. We would also share our ecosystem and our future plans. Yeah. So, yeah, Nick. I would like to share here a story. So we recently, in the month of September, we visited Udaipur at BHS. Now, BHS is Basic Healthcare Services. This is an NGO which was founded about 13 years ago by Dr. Pavitra Mohan and Dr. Sanjana Mohan. Now, these two are pioneers in this field, and they actually are pediatricians who are more focused on primary care and public health. And we visited basically to understand the work there and how we can be part of their work is what we visited this. And this is the story of a 32-year-old man. You can see him sitting there in the picture, you know, and that's the entire team. There are doctors from BHS. There's Dr. Nitin, who was a travel fellow at BHS. There's Dr. Gargi, who's another pediatrician working with BHS for a very, very long time. And you have B in the picture, and there's Dr. R.K. Prasad, and Prathamesh is somewhere maybe taking the picture. So this is the story of this 32-year-old man who had MDR TB, who got treated, but developed COPD and was unable to visit the healthcare center. Just to give a brief, BHS has clinics in these remote, rural and tribal areas of Udaipur. And these are very far-flung areas which do not have access to the population there. So these clinics are nurse-led clinics. And the doctors are available remotely, but also visit the clinic once a week. And that is called a doctor's day, where they see hundreds of patients. One doctor sees at least 100 patients, 150, 170 patients. So now this man could not come to the clinic because of COPD. He had a lot of breathlessness. And Dr. Nitin, the one you see sitting there with the patient, he gave an inhaler, a Duolin and a Budocort inhaler to this patient. But the patient was not able to come to the clinic. So he provided this inhaler to his wife and explained how to take. But then he wanted to ensure that the patient is taking it correctly. And so we visited the place at that time. This is a place called Morville, which is about 75, 80 kilometers away from Udaipur. So it's a totally hilly terrain. And we spent about 3 hours climbing these hills and reached this house of the patient. And we had to ask number of people on our way to find out where exactly this patient lives. And once we reached there, we wanted to see if the inhaler is being used properly by the patient. And if you can clearly see, just close to the patient, the inhalers are lying there, because we wanted him to demonstrate and show us how he takes those inhalers, uses those. So it's not just about that, but while we were sitting there, if you see, there are maize lying over there. That's their staple diet. And he shared that maize with all of us. And while we were sitting and having that, we saw that he has 4 children. I think 2 are there in the picture. And one of the child, he said, is about 8 to 10 years, but looked much younger, looked almost like 5-year-old, had all the signs of malnutrition, had the hair which was golden in color, could be easily pulled. She was very, very lean and had kyphosis. So we asked him, and had difficulty in standing or even walking. So we asked him what has happened with her. He says when he had this fever and cough and was being treated for his tuberculosis, the child also developed some fever and backache. But they have not taken the child to the hospital because her fever subsided. And we thought probably the child has pot spine and malnutrition. So we advised him to take the child to the PHC on a day when the doctor is there to have further investigation done, to have an X-ray, to have other investigation to do. So that is how the care was provided to this patient. So it's very difficult. How do you provide? So it's not just about clinical care that we provide. Can we go to the next slide, Akshay? So it's beyond just the clinical care. And that's where it's public health. So you cannot actually separate the two, saying that I'm just a clinician and I will only see the patient. And how do you see patients in these areas? The patient, if we see, we are standing on a hilltop. He cannot climb down or go up another hill because of his COPD and his breathlessness. So how does care reach him? And that is a challenge. And that's how, then BHS has trained nurses in providing care as nurse practitioners, and has trained village volunteers as sevaks, who are probably 8th or 10th pass people who take up this kind of being trained as volunteer village health workers. And so the care is coordinated from the doctor, nurse, and the village health worker. Of course, they also have a male and a female health worker who are under BHS, works under BHS. And these volunteers are actually not working for BHS for remuneration for their work in the villages, in the tribal areas. Yeah. So I just wanted to present this to show how do we bridge gap between primary care and public health. Akshay, thank you. So our health system is a very complex health system, and navigating through this complex health system is quite a challenge, not just for the patients, but even the doctors, the physicians, the cost to the healthcare services, and the cost, there are direct costs. We do not, many of the people are not covered by insurance. If you see this kind of a scenario where this patient lives in a tribal area, he does not have any insurance. Who covers his cost? It's out of pocket. And then there is the cultural and social issues. We had some of that also in this case. And then how does the logistics, how does a patient travel to even to the clinic, which is about, took us 3 hours to climb the hill and to find him, and took us another 2 hours to come down the hill. How does one access healthcare? So it's not just that, but even hospital, they are so complex. A patient who's not well educated can get lost in that system of the healthcare. And then individual health records, which Dr. Tanya also spoke about, that there are no health records available, not just at the PHC level, but at any level. There is no continuity of care, which is one of the main principles of a family medicine. The continuity of care can be maintained only when we have these health records of people, not just the individual, but the entire family. And how that is another challenge which we need to deal with. So can we move to the next slide? And I think this slide already Dr. Akshay spoke about. So this was in Africa, but I very much feel that every family physician, be it in Africa or India or anywhere, can provide these 6 roles and should be providing these 6 roles of a care provider, of a consultant, of a capacity builder, of a clinical trainer, of a clinical governance leader, and champion of community-oriented primary care. So which we will discuss about this, our model of care at Aveksha and PCMH Restore Health. I will request Dr. Prathamesh to take over from here. Yeah.
Thank you so much, Dr. Ashoojit, and thank you, everyone. Yes, so when we began our practice at Aveksha 3 years back, our vision was to redefine healthcare by envisioning healthy communities through providing team-based patient-centered care at the comforts of patients' homes or the communities that they live in. And we always believe in a team-based manner, where Dr. Ashoojit also mentioned we are a multidisciplinary team comprising of physicians, clinical pharmacists, psychologists, physiotherapists, dentists, and multiple other network of people. What we envision through this is to deliver world-class, compassionate, and comprehensive healthcare to people who are in these communities and improve their quality of life. Also inspire a lot of primary care practitioners. It could be clinicians, physicians, nurse practitioners, or multidisciplinary teams to provide this kind of a holistic primary care as their own mission and growth through them. Can we go to the next slide? Yeah. So we developed this integrative model where, as you see, the core crux of what we do is basically home-based primary care, where there is a multidisciplinary team providing care at patient's home. The other component of what we do is more of a training component, where we empower local community leaders or empower nurse practitioners through various fellowships, internship programs, career mentorship programs, and stuff. Also, we write what we do. So it's more of practice-based research that we do, and work alongside multiple such community health platforms like BHS, IPH, what Karuna Trust is doing, and several others across the country to provide the best possible care. And our core to provide care through all these things are based on empathy, wherein once you identify yourself on the other person's shoe, how would you like to be addressed at that particular point? Family-centered practice, where it's not just the patient or the family where we are looking at the disease pattern. It's also multiple other factors that would play a major role in this. Coming down to the integrated team-based, how can we utilize our team and empower people in the teams to take up this holistic form of care and provide a holistic approach to care? Also, listening to people makes a huge difference. Most of the patients that come to us would want to be heard or felt. Most of the times, the art of listening is compared to the act of listening. And most of the art of the listening just gets deteriorated, wherein we do not understand the patient well. And also incorporating community voice, hearing the community and being there for the community that we cater to is a major thing. This also provides a platform for continuous learning, and we believe growth happens to collaborative learning. Can we move to the next? Yeah. One of the highlights that Dr. Pawan also mentioned a couple of while ago was this part where we are empowering communities and utilizing the existing systems into providing the best possible care. This could be towards capacity building, navigating complex health systems, enabling community leadership through multiple levels. It could be at the medical officer level with the nurse practitioner alongside. It could be at the ashas in the community. It could be even in the local homes, a cluster or hamlets of homes, which can be empowered towards providing appropriate care. Next. Yeah. So this is a sort of thing that most of the family doctors provide to a patient or a family. They integrate the entire concept that the patient or family goes through. It could be logistics. They take care of the disease management. They look after the family dynamics. They also take care of the psychological, cultural, social, environmental, and other financial care as well towards the patient to provide the best possible care, be it in their home environment or at the clinic or at the community level. So most of us as primary care practitioners are doing public health on a larger platform. It's just about expanding our thoughts, moving out into the community and taking this forward, wherein we become like a bridge towards multiple segments that are providing care and help facilitate and navigate the right care to the patient. These are some of the papers that we have been publishing towards what we do, and we have been writing a lot of grants alongside. One of the paper that I would like everyone to go through would be managing these mental health problems in family medicine and community community settings. These are our own reflections from our practice. So the 16 points that you see on the right side, each of us would reflect multiple of these points in our own settings. How can we leverage these acts, or how can we leverage these small little nudges, bringing in multiple people, involving into multiple networks or systems, and helping the patient at the best. not just in terms of psychological care, but in terms of multiple domains of care. This was one. Next. We do also conduct training programs to multiple segment of healthcare providers, clinicians, and others. One of them was this with IPH and Chamarajnagar a couple of months back. Ashas, Anganwadi teachers and towards COVID-19 preparedness, sensitization, and early response system. So wherein they were empowered by the community leaders to enhance care. It was not just the COVID care that was mostly specified to, but the entire healthcare system. How can this bridge, or how can this bring in multiple other senses to the team and build capacity at whatever levels it is? I would request Dr. Ashoojit to speak on the future plans.
Yeah, thank you, Dr. Prathamesh. So I think Dr. Prathamesh has very clearly mentioned about, the art triangle, which says not just the clinical practice, but we have the training, an important part, and then it's the research or the publication of whatever we do, which takes an important part. And I think that is what bridges the gap between the primary care and the public health. And here is what we are looking at in future, transforming primary care across India or across globe, we would say. And the main here is the entire thing, which is driven by community orientation, where you have the urban underserved, you have the rural and the tribal remote settings, you have the ungrounded telecare, yeah, and then we have our Aveksha model, that is the home-based primary care. And the four main pillars of this, the transforming care, how do we transform primary care, is through a community-led home-based primary care. And then you have the learning system, where you have on-ground training modules, models, and the translational research, which Dr. Prathamesh very well explained how we do that. And he just mentioned about the training of the ASHA workers and the Anganwadi teachers and the school teachers, what we did in Chamarajnagar, or we have been training nurses as nurse practitioners across India for the last 2 years from the time COVID set in. And this is through online, of course, training, but with it's not just training or at one time, but a continuous mentoring and a follow-up with them and evaluation of their skills. All this is done by us in the last 2 years. I think we have trained around 25 plus nurses across India, along with the organization called Swasti. So that is one. Translational research, what Dr. Prathamesh just projected about all our learnings, which we write, and it's mainly for our, of course, for our own learning, but that helps a lot as a primary care physician. And we have the incentive-based model, where you have the micro entrepreneurship and the leadership, where you in the community, if you can develop, we already know about SHG, the self-help groups, but something more which can be developed to sustain a model of primary care would be more, is what we are looking at and thinking how we can reach there. Then you have the strengthening primary health care, which is through mainly here, this is what we feel that AFPI plays a very major role in empowering leadership through what we have already, the existing leadership program, which Dr. Dwiju spoke about in the beginning. Then facilitating accreditation, which Pawan was talking about. And we already have all this accreditation. We have looked at only accrediting clinics, but I think we can accredit. We are now looking how we extend this to PHCs or even small hospitals is what we are looking at in our future. Then leveraging networks across India or across the globe, how you can do that, and practice and policy policy transition. So all this is what I think is the value-based model for strengthening primary care, which we are looking at. And last but not the least, I truly believe, we all at PCMH believe, whatever you do will be insignificant, but it is very important that you do it. So we might feel that whatever we do, is very small, but we should continue doing that because it does make a difference. Every drop makes an ocean. Yeah.
Thank you so much, Dr. Ashoojit and Prathamesh.
Thank you, Akshay.
And I request the audience, if you have any questions for Dr. Ashoojit, Dr. Prathamesh, or any other panelists for that matter, please put them in the chat. We are running short of time. So before I move on to anything else, let me say that I'm sharing a link in the chat, which you can put your contact details on if you are interested in working for as part of, like Pawan was saying, as a group. If FPI has to do something, we need to create that workforce, that force team within us to be able to engage effectively. So if you want to join such initiatives, please do sign up, and one of us will get in touch with you. Any last comments from any of the panelists? Dr. Rao, are you still there? There are many questions at you about, in general, about what we should be doing, kind of things. Dr. Rao, others, any last comments?
Thanks, Akshay. We have already exceeded the time limit. I think most of us must be a bit tired of listening to us. I can say except that innovative in your practices, try to get out of your that four walls mentality and try and do something for the community and society around you, maybe for your fellow doctors also, and develop qualities of leadership. And this program which we are running is designed to help doctors to develop and become leaders. And every year it's progressing. And some of you who are kind enough, wealthy enough, you can be our donors for this program. It will help primary care as it is developing and in future. Thank you.
Thank you so much, Dr. I hope it was a useful session for everyone. I request Dr. Soumya to invite for vote of thanks, Dr. Swapna or Dr. Soumya. I'm not sure who is delivering it.
Thank you, Dr. Akshay. I think I'll do the honors. So I think this was such a different and totally enriching session for probably clinical practitioners like us who don't think beyond your clinic, like Dr. Rao said. See patients definitely, and without understanding that we're doing some kind of public health also there. But it took me actually to a different perspective of thinking about family medicine and community medicine being bridged. So, and wholeheartedly thank all of you who joined this, the delegates, the panelists, Dr. Dwiju and Eric, I think all the way from US, the whole team of PMCH Restore Health, Dr. Rao sir, and of course Akshay for so wonderfully engaging everybody through this 1.5 hours of session. So we look forward to seeing you for our next CME, which will happen soon. We'll be in touch. Thank you all for being part of this, and good night. See you all soon.
Thank you. Thank you, Dr. Swapna.
Thank you.
Thank you, everyone.
Thank you.